we're going to march into a video here presentation on return to work. So if we can get that started.
Hello and welcome to an update on nursing home staff returning to work safely during COVID-19. First, I just thank each of you for the work you're doing, whether it's serving patients on the front line or working behind the scenes so that clinical work can continue. Your contribution to the well-being of vulnerable older adults cannot be overstated. I know from personal experience that it has not been easy to get up every day and keep doing this work, but it's so necessary and it's so valuable. So thank you so much. My name is Abby Parrish, and I'm a geriatric nurse practitioner. I'm also an associate professor of nursing at Vanderbilt University. I practice at local long-term care facilities here in Nashville, Tennessee. What I'm going to be sharing today will be a combination of best practices from the CDC and other organizations, alongside practical guidance about some of the challenges that have gone beyond the guidelines, so to speak. So today's presentation will address a checklist to use to determine staff's readiness to return to work, alongside strategies to improve staff disclosures of symptoms and ways to reduce potential staff shortages. Before we talk about returning to work, let's quickly refresh on the illness trajectory of COVID-19. So after someone has an exposure to the coronavirus, there's an incubation period during which time the virus is present and replicating in the body, but not yet actively causing symptoms. So the median incubation period for the virus has been estimated as being about 4 to 6 days, with some incubation periods being measured as short as 2 days or as long as 14 days. For many people, this is followed by a symptomatic period. The duration of symptoms varies depending on severity of symptoms, with more severe symptoms lasting longer. A common duration of mild to moderate illness is about 10 days. And interestingly, the period of time during which people with COVID-19 infections are the most infectious to those around them is the few days at the end of the incubation period and the first few days of symptoms. In persons with mild to moderate infections, researchers have not retrieved replication-competent virus past 10 days of symptoms. So that is, we think folks are no longer infectious by day 10 after symptoms begin. Of course, there are also folks who become infected with SARS-CoV-2 and never display symptoms. Researchers suspect that folks with asymptomatic infections are probably about as infectious as symptomatic people and for about as long. Because these people never develop symptoms, they may be going about their usual activities throughout the duration of their highly infectious period. So when combined, the disease trajectories of symptomatic and asymptomatic persons include a significant amount of time during which persons are asymptomatic yet infectious. So how do we keep infectious folks out of our workplaces? This is particularly relevant in long-term care settings where most workers will be in close physical proximity with vulnerable residents and other staff members throughout their shifts. So the easy answer would be to keep everyone at home who is possibly infectious. That is, everyone with any potential exposure. But of course, if we did that, it could be difficult to meet states' safe staffing needs. So in the context of rapidly increasing community prevalence and exposures, facilities are faced with the challenge of balancing the desire to keep infectious folks at home with the need to ensure adequate staffing and safe staffing ratios, often for really high patient censuses. So for the remainder of this presentation, we're going to discuss return to work policies that aim to balance these competing safety needs. So let's refresh on a couple of definitions that turn out to be really relevant to return to work policies: quarantine and isolation. So quarantine is the term that's used when someone has been exposed to the virus and stays home while they wait to see if they're going to develop symptoms. Isolation is the term used when someone has a confirmed case, either symptomatic or asymptomatic, and they're staying home to avoid infecting others. So one thing is certain: people with symptoms should isolate at home. This measure will remove many infectious folks from the workplace. If a staff member comes to work feeling healthy, but then develops fever of 100 degrees or higher, or if they develop symptoms during their shift, they should inform their supervisor and leave the workplace. Facilities should have plans in place to respond to outwork symptom onset with testing and backup staffing. The CDC has guidelines advising when staff members with symptomatic infections may return to work. So on this slide, you'll see a checklist for staff members who have had mild to moderate illness, and this checklist should be used with the staff member on day 10 of symptoms. If the person has been fever-free for 24 hours without the use of fever-reducing medications, and as long as their symptoms have improved, they may return to work. If they still have symptoms, they should wear a surgical mask rather than a cloth face covering until their symptoms completely resolve. You'll recall that the 10-day symptom duration was selected because that's the amount of time that researchers have measured replication competent, that is infectious, virus. Unfortunately, most folks, though, will have a replication incompetent virus detectable in the respiratory tract for days or even weeks after their symptoms resolve. The light blue bar on this slide shows the duration of time that folks may have a positive test. It begins about the time they become infectious and lasts until days or even weeks after their symptoms resolve. So the CDC does provide a way to return to work using testing, but for most folks, returning to work 10 days from symptoms onset will be faster. But the CDC does allow folks to return to work once they've either had 2 negative test results that were taken at least 24 hours apart, or when they're at 10 days after first symptom, whichever comes first. For the person who experienced severe or critical illness, or for the person who is immunocompromised, the checklist may be completed between at least 10 days after symptoms beginning and up to 20 days since the first symptoms. And due to the complexity of these cases, the CDC suggests consulting with an infection control person about return to work for the cases if you're in doubt. Now let's discuss return to work for asymptomatic cases. So in post-acute care facilities, these folks were often discovered to be infected as part of routine facility testing. Asymptomatic cases follow the same return to work guidance as symptomatic cases because, again, we think these folks are about as infectious and for about as long as symptomatic folks are. So asymptomatic cases should wait 10 days since their first positive test. And it is a little bit more common that these folks might have follow-up tests come back negative. So it could also be reasonable to use a test-based strategy for this group and begin retesting them with a return to work occurring once they've had at least 2 consecutive negative tests, which were collected at least 24 hours apart. Now, just like symptomatic cases, staff members who are severely immunocompromised, but who are asymptomatic throughout the infection might need to wait a little longer to return to work and should be assessed between 10 days after their positive test and up to 20 days have passed. And again, this might be another situation in which a consult with an infection control specialist could be useful. Okay, so those were the more straightforward cases. Now we get into the murky waters. What do we do about folks who have been exposed to the coronavirus but have not yet become symptomatic or have not yet had a positive test result? So when we talk about exposure, we're really going to want to distinguish, was this an exposure in the healthcare setting where PPE was likely in use, or was this an exposure in the staff member's household when PPE use was unlikely? So let's talk first about facility exposures. The CDC classifies an exposure as close contact that was within 6 feet for a total of 15 minutes or more, and those 15 minutes do not need to be consecutive. In the healthcare setting, it is inevitable that workers may need to have this sort of contact with COVID-19 patients, and that's okay as long as PPE is used appropriately. For certain exposures believed to pose a higher risk for transmission, the CDC recommends that exposed healthcare personnel be excluded from work for 14 days following that exposure. So the exposures are listed on the slide here. So that might be a staff member who worked with a COVID-19 patient while not wearing a respirator or surgical face mask, staff who were not wearing eye protection if the person with COVID-19 was not wearing a cloth face covering or face mask, or staff who were not wearing any suggested PPE during any aerosol generating procedure. So for any other lower risk exposure, the healthcare personnel may continue to work. However, the CDC does recommend ongoing screening for symptoms prior to starting work each day. So considering that the CDC guidance for exposure is at least 15 minutes within 6 feet of someone, and considering that household members rarely wear PPE around one another, household transmission is extremely common. And the CDC does advise that household contacts of a positive case quarantine for 14 days. If the staff member who's been exposed at home develops symptoms, then they can shift to the return to work guidance for cases. So regardless of where an exposure occurred, it would be really nice if we could use testing to affirm that someone either did or did not develop an infection post-exposure. The challenge for testing is right here. So that up to 14 days incubation period. So while most folks will begin to have a positive test result within just a few days of exposure as they enter their highly infectious period, some folks will have a longer incubation period. So a test at say 3 days or even 7 days post-exposure might show up negative, and yet they could still develop symptoms. Testing only identifies the presence of the virus at that exact time of the test. Some folks choose to get tested post-exposure, but they need to be advised that a negative result does not mean they will not develop infection. And this is the rationale for the 14-day quarantine period post-exposure. So the CDC does note that if staffing shortages occur, it might not be possible to exclude exposed healthcare personnel from work. In response to that, some individual facilities have adapted somewhat less restrictive policies than the CDC as they balance the need for safe staffing ratios. So for instance, some facilities might allow folks who have been exposed at work or in the community to work as long as they're symptom-free. This decision should not be undertaken lightly because it's associated with the risk of transmission to other staff and patients, which could further exacerbate staffing issues. Due to the very high risk of transmission in homes, most facilities suggest quarantine for staff members with confirmed cases in their household, regardless of staffing challenges. So at this point, you could be feeling like it's inevitable that at times we're going to have staff members at work who are asymptomatic or who are pre-symptomatic and are infectious, regardless of how well we follow CDC guidelines. That is absolutely correct. So the CDC does advise that our residents wear a cloth face covering or face mask if tolerated whenever they leave their room, including for procedures outside the facility. Cloth face coverings should not be placed on anyone who has trouble breathing or anyone who's unconscious, incapacitated, or otherwise unable to remove the mask without assistance. So keeping face masks on our residents is obviously really challenging, particularly for our residents with memory impairment. So having residents wear face coverings is something that we can continue to make a good faith effort to accomplish while recognizing that 100% resident adherence may be impossible. As we've all experienced, they can be quite a gulf between knowing about CDC guidance and putting it into practice in individual cases, each of which will be unique. So I'd like to finish today with some practical tips for putting CDC guidelines into practice. So first, a little bit of prevention may go a long way toward enacting return to work policies. So I remember the first time after COVID emerged that I had a cough. My mind was racing with so many fears, worries, and in that cognitive haze, I could not remember, nor could I easily find my workplace's policy for going to work with symptoms. One of the most helpful things we can do for employees is to communicate early and clearly and often about what we would want them to do if they felt symptomatic. So people who come to work or who stay at work while symptomatic, they may be really well-intentioned. They may not want to abandon their patients or their coworkers. They might fear making a big deal over nothing. They might fear loss of pay, or they may simply not know what to do. So everyone needs to know without a doubt what the facility stance is. And the facility stance will probably be something along the lines of anyone who has COVID-type symptoms will be doing the best thing for themselves and for their coworkers and for our patients if they stay home. So framing it in that way also conveys that your priorities are to your employees and to your patients' safety and well-being. So next, another great thing to do at this juncture would be to take a look at your sick leave policy and take a look at it through the lens of someone who is worried about COVID-type symptoms. Does your sick leave policy incentivize what's known as presenteeism and discourage absenteeism? So if it does, this could be a great time to go ahead and adjust it and to clearly communicate the changes to your employees so that they are comfortable staying home when they need to. And also take a look, is your sick leave policy flexible enough to adapt to what we know are some very unique conditions in this pandemic? And if not, that could be another opportunity for adjustment. So I read a really great article by Rebecca Georges and Tamara Konecka from the University of Chicago, and it was published in the Journal of the American Geriatric Society. They took a look at the pattern of COVID outbreaks in nursing homes, and they concluded, quote, "The strongest predictor of nursing home COVID-19 outbreaks is per capita cases in the county." Per capita cases in the county is 100% out of our hands, unfortunately, which means that nursing home outbreaks are not the fault of the leaders or the frontline staff. So during times of high per capita cases in the county, nursing home staff members will have more potential community and household exposures, even if they're meticulous in avoiding large gatherings and they're always wearing a face covering when they're outside the home. During periods of high community transmission, staff may have unavoidable exposures from children attending school or daycare, from partners who are exposed in their workplaces, or even from the completion of essential errands. So when case counts in the county get high enough, the natural history of COVID infection makes an outbreak in our facilities likely. This is the tragic reality of COVID-19. So be transparent about that with your staff. Communicate that you understand that they may have unintentional but necessary exposures during times of high rates of COVID transmission in the community. This reduces the shame that staff might feel in disclosing symptoms. Affirm that you understand what it takes right now for all of us to make ends meet. 2 partners going to work, childcare, elder care, etc. And these things have associated exposure risk. Tell your staff you know that everyone's doing their best and affirm how much you appreciate what everyone's doing to keep the facility running during these very, very hard times. Be transparent with the staff about the work you're doing to prevent and mitigate outbreaks. Send them COVID updates. Be clear about your goals. Highlight shared goals, things like reducing facility transmission, which will ultimately make everyone's jobs easier. So this sort of transparency and support on the part of leadership will support staff being free to be transparent about their own symptoms, their own exposures, and their own questions. The CDC has a guide for mitigating staff shortages, and I've got the link on your slide. If your facility is anything like mine, you've been experiencing shortages of one type or another throughout the pandemic and are only seeing that escalate with this newest case surge. The CDC suggests beginning to address staffing shortages via strategic planning in advance, followed by transfer of patients to other facilities as indicated. And you're going to want to check out the CDC site for more details about these steps if you haven't already. So if all of those measures have been exhausted, the CDC does outline modifications to return to work policies that could be considered in a stepwise manner during times of crisis. So if these are utilized, patients and families should be informed, and any step that's taken should be reversed just as soon as the staffing crisis abates. So we touched on the first step of return to work crisis staffing earlier in this presentation, and that would be that asymptomatic folks who have had a known exposure might be allowed to continue to work using appropriate PPE while they wait on their test results. As staffing crises worsen, staff who have had positive tests but remain asymptomatic might be able to perform activities that do not bring them in direct contact with other staff or patients, such as telehealth. And then during periods of more extreme crisis, staff with confirmed cases who are asymptomatic might care for patients who are also infected. This has been implemented in North Dakota, and the North Dakota Nurses Association has come out in opposition to that measure, stating that the decision to continue working should be up to individual nurses rather than to their employers. Finally, as a very last resort during a time of severe crisis, staff with confirmed infections who are asymptomatic might care for patients who are uninfected. I want to thank you so much for learning with me today. I see you and I value your commitment to your residents. Thank you so much for all you're doing. Your work is so important. Please don't hesitate to reach out to the organizers of today's presentation with questions or with ways that future activities could better support your learning needs. Thank you.
Yeah, so we'll do some review of that issue. I just want to point out that there's some things that we still don't really know. So, for example, they were talking about the staff exposure to somebody who was not wearing a mask but who has COVID, and we don't know what about if it was partial masking. So if you had somebody that had the mask down below their nose. There's no guidance, for that. So presumably that mask was counting, but if you're like seeing older adults, like I see in my clinic in geriatrics, 100% of my patients can't wear a mask over their nose for some reason. And so I'm sure that is a similar issue that we're all experiencing. So again, no clear guidance. I don't know if Kelly or Jean, we don't have Faye on today, but you might want to think about and comment about, something like that as to how to handle a case of partial masking.
Yeah, and in my thought process, I would still consider it as your exposure like you would any other case, especially for your staff, just to be on the safe side.
Yeah, it's always prudent to be on the safe side. And I just want to mention that we look at the CDC website fairly frequently, and the current recommendations on return to work are still under the guidance of the February 16th recommendation. So there's no new updates over the last 6 weeks. So basically what's been presented today by the Institute for Healthcare Improvement is fundamentally the same recommendations as prior. So why don't we go ahead?
Excuse me, Dr. Jurevich. I would just add to that our Department of Health has updated the return to work guidance for our state to include the fully vaccinated persons. And there's basically what it says is there's no need to quarantine unless there are symptoms, even if it's a high risk exposure. So just to keep that in mind.
Yeah. Thank you for that clarification.
Yes.
Yeah, because the guidance on the CDC doesn't really talk about the vaccinated worker in that guidance. So, okay, good. So Jean and Kelly, can I hand it off to you then for the case studies?
And just to tag on, absolutely make sure that you're still checking CDC, your state guidelines. And I'm not sure if both Dakotas have the same guidance. And then I think we have some facilities from Minnesota, is that correct? So just make sure that you're verifying, and then your county as well, because based on your positivity rate in your county, you may have different guidance there as well. So I've also recommended to a lot of facilities that I'm working with is talk to your program manager closely with the survey agency, and they may be able to provide you some direction too, because you definitely don't want them coming in and citing you on something that they're following. So I'd look at all of those places for sure. You can go ahead and go to the first slide there. Awesome, thank you. Okay, so our case study today is about staff returning to work, and I'll read this out to you, and then I have a few follow-up questions that I'll ask if you can respond to in the chat. So Pamela, CNA, contracted a moderate to severe case of COVID and was hospitalized for 3 days. When she returned to work, she remained weak and short of breath for a few more weeks. She gradually returned to her previous level of function, walking 1 to 2 miles a day, and she also regained her appetite and energy level. So now she wishes to return to work. And I'm sure all of you have seen something that's similar to this, since this has been going on a year now. I know when we did these presentations, the first go around, it was still fairly new, staff being out of the facility, but this, I know you guys have probably seen multiple times. So go ahead and go to the next slide. So the first question is, under what conditions can Pamela return to work? Does she need to have 2 documented negative COVID tests, or can she return to work based on the resolution of symptoms and 14 or 20 days of isolation? Now, we did touch up base on this just a minute ago, is that what is the guidance from your state or your local authorities, and how would you respond? So we may have a variety of answers here, but I'd like to know what you guys are doing. And then Jean, jump in if you have any information directly for the Dakotas. And my next question, as people are responding in the chat here, is, do you know where to find your guidance for either your state or local authorities? And if so, you can share that in the chat as well. There may be some folks that are new to the facility or new to the area, and they may not be aware of where to locate that stuff. And another note I would make is that as guidance changes and rules change, do you have a plan of how you're communicating that to the staff or communicating it to residents and family members? I talked a little bit in the video about making sure that you're transparent with the staff and residents and family members. So how are you doing that communication? And Jean, did you have something?
Well, I was just going to mention that in the video, she referenced the test-based strategy as an option for bringing healthcare workers back to work. But actually, test-based strategy is no longer a recommendation, except in extreme cases. So just bear that in mind. It's basically now the time-based strategy.
Right. And as Jean also mentioned, now based on whether you've been vaccinated or not, would make a difference as well. So there have been changes since these presentations were originally put together. So just make sure you know what those changes are and that you've communicated that to your staff and they are aware of that too. I think something that has been a struggle too is, how do the staff, not only are you communicating it to them, but if they're in a dire situation, do they know who to contact to ask, hey, is it the staffing coordinator that can give them direction on whether they can return to work or not? Do they have to go all the way through the DON? I mean, do they know where that communication line is? Because you definitely don't want them to come to the facility and then expose others because they don't know what the steps are.
Mm-hmm.
Great. And Dr. Jurevich put some information in the chat there for you guys about folks that are vaccinated and what criteria they need to meet in order to return. Do you want to speak on that, Dr. Jurevich?
I just copied from, that's the North Dakota Smart Restart Guidance. And not to put a fly in the ointment, but as we're getting into the allergy season, what constitutes symptoms or not, with people with runny noses, nasal congestion, sinus headaches, you have to go to a testing strategy there. If they say, oh, I've got, these are my old symptoms, you can't rely upon that. So again, a smart start requires some smart thinking to cover all your bases. So it's best to be on the, I like to say, the safe side of things. And if you do have a test-based strategy for an essential worker, that would be the way to go.
Yeah, no, absolutely. I agree with that. And, at the very beginning of this pandemic, one of the facilities I was working with, they had an outbreak. And I was like, did you determine the source of your outbreak? And they did. They had two staff. One had just received the flu shot and they attributed their symptoms to the flu shot. And one attributed their symptoms to just the common allergies. And both of those were positive, and that then infected 15 of their residents. And so it's very important that you look at those cases closely. And if you have the capability to do that testing strategy, go that route.
Yeah, I would agree. And then also to point out that unfortunately 5% of the RNA vaccines don't work. And if you just happen to be that one person that was the 5%er, that could be an issue too. So you can't rely upon the vaccine as being 100%. It's pretty good, but again, we just need to be mindful of the fact that there might be some folks slipping through that who were not adequately vaccinated. And the same thing occurs, by the way, with if you've had bona fide COVID within the last 3 months, you're also exempted from quarantine, because you have that infection. But beyond 3 months, you then have to go through the whole quarantine process again, right? Because they don't know what your immunoprotection is after 3 months. Even with the vaccine, they're saying 6 months currently. So there's probably going to be some guidance going forward as we learn about the duration of the vaccine itself. So sorry to interrupt.
No, you're good. You're good. And thanks, Terry and Michelle, for your responses too. They're pretty similar. Your improvement without a fever in the 24 hours without the fever reducing medications. So that's been pretty standard, I know, since the beginning, once all those symptoms have resolved. So we can go to the next question. All right. Now, next question is, can Pamela work with any and all residents, or must she work with the COVID-19 positive residents? And I would just be curious too, while people are thinking of a response here, is how many people actually still have a COVID unit right now, or an active COVID unit, I guess I should say. You may still have it set up, but just nobody in it. That is the ideal situation, right?
Yeah, I was actually looking at information from Michigan Department of Public Health, because they have an uptick in cases across the state, but there's no information about the nursing home cases there in terms of whether the variant has infiltrated into the long-term care. But I think we need to be vigilant of that as the variant is starting to rise and becomes more infectious, that we just remind ourselves of what these policies are.
Absolutely. And just don't forget either, is as you have new staff coming on, that you are educating those new staff on those policies as well. And it's very important that all staff are aware of it. When you have a family member who comes in, and say you're opening up visitation to some degree, and you have family members come in and they ask questions about what you're doing, you're really moving in the right direction when any staff can explain that to a family member. It builds the confidence in the nursing facility as a whole. And it looks like most of you, they don't have an active unit, but you do have supplies ready to move forward. And definitely, yeah, she still needs to wear the PPE that everyone else is wearing, but nothing special. And I think that's actually, the next question. So I could think you beat me to the punch, Michelle, but you can go to the next slide. Yes. Does she wear full PPE based on the previous COVID status, or use the PPE depend on the status of the residents she's caring for? So yes, she'll be using the same PPE as all other staff because her symptoms have resolved and she's able to return to work. If she was required to wear the full PPE, then she probably wouldn't be back at work, right? So I think you guys have kind of touched on that in your response to the previous question. All right, and I think you guys all have a good plan. I know this is definitely a year into it, so you've had much practice. I was actually on an echo call yesterday covering for one of my counterparts at TMF, and we talked about, there's so many opportunities and lessons learned throughout this year, and really take that all as a quality improvement opportunity. Where have you seen yourself shine and rise above during this trying time, and how can you implement those positive situations to move forward and prepare? And the one other comment I'll make, and I'm going to turn it over to Jean for the next case study, is your facility assessment. I encourage everybody to go back, if you have not already, and look at your facility assessment and look at that that section on your disaster plan about what your response is to a pandemic. I laughingly said that when I was still in the facility, which has been 3 years ago, I think my section on response to a pandemic was about that big. I just really don't think that we as an industry were as prepared for something of this nature. So really go back and look and make sure your policies and such are in place, and that you have a plan moving forward. Okay, I'll turn it over to Jean for our next case study.
Okay, well, let's go ahead and just move to the next slide. While I was preparing for this, I thought it's very likely that the only constant during this pandemic has been our recommendations for hand hygiene. This hasn't changed. The pandemic recommendations are the existing hand hygiene recommendations. So the case that you're seeing on the screen is actually a case that occurred here in North Dakota during a recent survey, one that was conducted this winter. So I'm just going to share it with you. During a recent infection control survey, surveyors observed a CNA approach a sink in the East Hall. She used her left hand to dispense the soap into her left hand without rinsing her hands first. With her right hand, she turned the faucet on and then began soaping her hands. So after she dried her hands, she was asked about the sequence of soaping before rinsing her hands, and her reply was, "I was just a little distracted." So in chat, I would just like each of you to chat in how you would handle this situation. How would you address this citation deficiency?
And while people are responding in chat, Jean, I just wanted to throw in, when I was still in the facility, I created more than I want to believe acronyms for staff when there were certain steps in something they needed to remember. And you would have to look at the full steps for hand hygiene, but it's just something to consider. They could wear it on the back of their name badge or something as a quick reference, because there are a lot of steps to it.
Yes, there are. I think one of the things that you would want to do is first go back. Oh, here we go. Is first go back and look at your policies and be sure that they're very clear on the soap and water technique. And we have Michelle saying that education on appropriate procedure at the time. That's true. Real-time education is very powerful. Yeah. Educate and re-educate staff on a regular basis. And again, not forgetting to educate on the updated information that we receive. Begin with a hand washing audit. Absolutely. Education, audits, and visual aids at the sink. I think the visual aids are very important. Yeah. Okay, great responses. So do your frontline staff know where to find procedures for hand hygiene? If you don't have something posted by sinks, do they know where to go to find this information? You can just answer yes or no in chat. And if this occurred in your facility, would you be able to demonstrate for your staff the proper technique? Hand hygiene posters are at all sinks. Everybody says yes, they would be able to demonstrate. Perfect. Perfect. So, and then just out of curiosity, I'd like to know when you conducted your last hand hygiene audit. Have you done one in the last month? Has it been 2 to 6 months? I'm seeing weekly, 2 weeks ago. Monthly, ongoing. Perfect, perfect.
So I guess the other question, Jane, is as we're seeing folks are doing the audits, are they documenting their percent compliance with the staff? You know, so these don't have to be big numbers, but if you're are doing audits and you've got, let's say, you've observed 10 to 12 staff members, then do you identify, are they 100% compliant, 80% or whatnot?
Yep, absolutely. And share that, yes. I see that Michelle says that they did a QAPI PIP a month ago. Michelle, in a few minutes, we're going to be walking through a QAPI PIP on hand hygiene, and I would really be interested in having you on mute and chime in with your findings and the strategies that you implemented. Okay. Well, very good. They did, Charlene said they did 90 audits in March alone. They do them monthly. Perfect. And Charlene, I know that you share results back to your staff. All right, next slide, please. So here is the hand hygiene PIP. Kelly, do you know, has this been shared with this group before? I haven't been on a lot of these calls yet, so.
No, I don't think we've shared this particular PIP with this group yet. And really the idea behind this is that we want to give you an example of a hand hygiene PIP. Now, I will say it's very important that each organization or each facility does their own root cause analysis to put interventions in place when you're building a hand hygiene PIP. This is simply an example. Because it could be that maybe you find out that you don't have enough hand sanitizer stations throughout the hallway, and that's the reason they're not automatically doing that, or they don't have them on their person. It could be that you didn't do any return demonstration during your training and they were just going off of reading a sign and go in service, as I used to call them. And so it's very important that you do that. And I think the real key points to a PIP, in my opinion, is one, the root cause analysis. You really have to determine out what the reason that your compliance is off. Number two is creating that SMART goal. It really helps in holding you and your team accountable for what the intent of the PIP is. And number three is having monitoring and measurements in place. As Dr. Jerovich said earlier, when you're doing all those audits, are you documenting them? Are you able to see the progress or the success of the PIP that you put in place? And, you know, I believe I mentioned, sorry, we're off routine on these sessions. So I think I've mentioned the 5 attributes to you guys before in interviewing 5 staff. And you can use that as your monitoring tool. I'm going to interview 5 staff every month and ask them, when is hand hygiene done? Where is it done? Who does hand hygiene? Why is it done? And how is it done? Or what tools am I needed to do it? If you can ask those 5 staff and see if you can get the responses. If you're getting 5 staff every month that are able to answer those questions about this process or training you've put in place, your system is reliable. And so that's just another example of how you can monitor or measure your results by doing that simple process. And I know I say it all the time, but you're rounding every day. Put it on your rounding checklist. You're having the conversations with the staff, just put it on that rounding checklist and you can check it off. Don't overwhelm your resources by having every leadership staff observe 10 people every day. That may be too overwhelming and then not be as successful. So try try to keep it small and simple when you can.
I remember from our previous cohorts that one of the nursing homes shared with us that they sent that they didn't just observe in the hallway, that they actually went into the resident rooms and did observations, and the findings were very, very different from the findings in the hallway. So that's just another strategy you can use to bolster your hand hygiene.
Absolutely. And you really build the confidence in the staff when you are observing them. Most staff, I know that when I was in the facility, I can say with certainty that staff would say, I was just nervous because the surveyor was watching me. Well, it is nerve-wracking when someone's standing over your shoulder, but if they're used to someone standing over their shoulder, then it's easier. The other thing is, if you don't already do some sort of skills fair on an annual basis, if you don't have hand hygiene on that rotation, then definitely consider adding it there. It's just another way to reinforce that return demonstration practice for the staff. And we can go through the other slides of this PIP. I just wanted to reiterate that this is a sample. I don't want you guys to just print it and put it in your copybook, because that wouldn't be helpful, because it's not your facility specific information. But this is a tool that Michelle Lochner had provided us, that the Great Plains Quinn has developed, and it's a really great at a glance tool. I prefer those working so I can see everything in one space. And so this is a great, it's only, I think it's 2 or 3 pages. It's fairly short and sweet. So. Oh, actually, I believe there's audit tools on here too. Yes, this is just an example of the actual audits and how you can measure it. This is attached to the same PIP. It's in an Excel file. So all you do is put the number of audits completed and the number of audits passed, and it automatically calculates that percentage for you to monitor whatever PIPs you have in place. So it's a great way to show your entire QAPI team, because maybe you have your ADON, a CNA, and even maybe a housekeeping staff who are on that PIP team for hand hygiene. And so on a monthly basis, you may report this up to the QAPI committee of how those audits are going. Dr. Jurovich has mentioned this before too. I know the buddy system, if you have those buddies, they can help with the hand hygiene observations and audits too. It may make it a little more comfortable for your peer to come up and say, hey, by the way, you missed that step, or you went out of sequence. Just a reminder. Or maybe you have a competition per unit, and everybody gets in and tries to do it all together to win that competition, and then they'll be more likely to help each other out. So I believe this is on that same Excel file. Jean, you may be able to correct me, but I believe this is from that same Excel file too. It's just kind of updates of how your PIP process is going and what you've been doing. And then the actual charts. Now this may be something better for if you have a board of directors or your medical director, to be able to see something more graphic. And even this would be nice to put in a newsletter to your family members saying, hey, we recognize that we had this issue, because you're going to be transparent, right? We recognize we had this issue. We put this plan in place, and look where we're at now. Or just a staff newsletter, if that's another way to show, look, guys, you really worked hard, and this is how much we've improved.
Yeah, I like the idea, Kelly, of sharing this information with family members, because it is actually helps remind them, right? As we're trying to open up the facilities, they go, oh, if they're working on hand hygiene, it's going to sink in my brain that I've got to be good with my hand hygiene, if not while visiting the facility, even at home. So these can actually help disseminate best practices, about wearing masks, social distancing, and hand hygiene. So very good. Yeah.
Even community events, you can, if you want to build your reputation in the community And it's a double-edged sword. You can use it almost as a marketing tool, saying, hey, look at all the great things we're doing here amidst this pandemic. And then it doubles as a reminder to everyone in the community: wear your mask, safe distance, use proper hand hygiene whenever you're out in the public. So.
Very good. I think that was, yeah. So we just wanted to ask, I think we covered this, you know, with how the audits are going. Why don't we head into our summary slide here, so we can kind of get people going here in the holidays. So just remember I guess we're off of all the lakes have thawed out here, so maybe this slide was a little bit more appropriate a few weeks ago. But again, just remember the 15-minute exposure within a 6-foot radius. And at the time of exposure it's cumulative. It's not just at one moment for those 15 minutes. Next slide, please. So for staff to return to work after a symptomatic infection, it would be wise to use a checklist, a registry, so keep a log. And then after 10 days of isolation, ask if they're fever-free without the use of Tylenol or non-steroidal anti-inflammatories such as Advil, Motrin, Naprosyn, and so forth. And then also to see if the symptoms are improving. You know, a lot of times people will have that nagging dry cough, and that may be an issue. And then finally, you know, to return to work with a surgical mask if a residual cough. We talked a little bit about the, you know, some of the enhancers of masks. You know, they have those kind of rubber or plastic frames that you can put over a mask to get a better seal too. That really is, you know, dependent upon your PPE policy and inclinations to use those, but they are more effective. Next slide, please. So the idea is that you return to work after asymptomatic infection, so 10 days after the test, and then with the caveat about the vaccinated people, as we stated earlier. Next slide, please. And it's important, and this happens, right? There are people with working with rheumatologic conditions, and they're on immunosuppressants. So the cutoff for prednisone is greater than 20 milligrams per day. That would include both somebody with COPD, for example, that was pulsed with 40 milligrams of prednisone, as well as people that are on chronic prednisone. So when in doubt, consult your medical director. Next slide, please. So in terms of the exposure, so if it's a high-risk event, you know, particularly with the aerosolized things, we often talk about the CPAPs too as being a potential source of aerosolized droplets. But basically the guidance is that if you're giving somebody a nebulized treatment, that would be considered a high-risk exposure. In terms of the low-risk exposure, no quarantining, but more frequent testing, so that you can have that individual continue working, but just screen more frequently. I see also with the Michigan nursing homes that there's something like 140,000 antigen tests that they've distributed to the nursing homes. So they're actually, even though the county relationship is stable, they're still doing more testing. Next slide, please. Yeah, so the 14-day quarantine, just as a reminder. Next slide, please. And then the adaptations that we need to take where you know, folks are infected but asymptomatic can work on the COVID unit if that COVID unit is active. It doesn't make sense if it's not active. And then with lower risk exposure, they may continue to work as long as, again, using the symptoms as your guidance.